Welcome to the Currents of Public Health webinar series, presented by the School of Public Health at Georgia State University. My name is Brian Greer, and I'm the Director of Development for the School of Public Health. The goal of this series is to explore relevant public health topics with members of Today's topic is the role of SARS-CoV-2 Serostudies for monitoring burden of disease and associated risk factors. Our guest is Dr. Heather Bradley. Dr. Bradley is Assistant Professor of Epidemiology and Biostatistics at the School of Public Health at Georgia State. She is an epidemiologist whose main research interests include HIV prevention and treatment outcomes, surveillance methodology, and the intersection of infectious diseases with the U.S. opioid epidemic. Prior to joining the faculty at Georgia State, Dr. Bradley worked with the Centers for Disease Control and Prevention in various divisions, including the Division of HIV/AIDS Prevention and the Division of STD Prevention. From 2016 to 2018, she was the Associate Chief for Science for the CDC's Division of HIV/AIDS Prevention, where she oversaw the training and research of more than 50 epidemiologists in the Behavioral and Clinical Surveillance branch. Today's webinar will be guided by three general questions. What are you doing? Why is it important? And how can we get involved? One quick note, if you have a question at any point during our conversation, please feel free to type in the Q&A box and we will try our best to answer. So let's begin. Dr. Bradley, welcome to the webinar, and please tell us about your research and what you're doing.
Thanks so much. I'm excited to be here. So I'm going to be talking today about the role of SARS-CoV-2 Serostudies for monitoring burden of disease and associated risk factors. So as Brian mentioned in my intro, I'm an infectious disease epidemiologist with a strong interest in surveillance. And what that means is that I'm really interested in measuring how widespread infectious diseases are in populations, and particularly interested in disparities between populations in terms of burden of disease. A lot of my research is focused on racial and ethnic disparities in infectious diseases and how we can best use data to reduce those disparities. So let's jump right in. Like many people, you know, I do typically work in HIV and hepatitis C, but I've become increasingly involved in COVID-19 research since March. And so these are surveillance data about COVID-19. They're taken from the Georgia Department of Public Health's website, so from right here in Georgia where we live. And they indicate that as of today, we have over 309,000 confirmed cases cumulatively in Georgia. Nearly 28,000 hospitalizations, and we're getting close to 7,000 deaths. In the last 7 days, just over 10% of COVID-19 tests have been positive. And so as a researcher who is really interested in racial disparities, I always say that the averages don't tell you very much, and so you need to drill down a little bit and see how these numbers are distributed across populations. So in the case of Georgia by race, and here we're looking at the confirmed cases number, we see about 35% of our cases are among non-Hispanic Black people who make up about 33% of the Georgia population. 41% of cases are among non-Hispanic white people who make up about 52% of our population. And 17% are among Hispanic or Latinx people who make up about 10% of the Georgia population. And so you can see there are some disparities there in terms of how cases are distributed versus how people are distributed in the population by race. One important caveat is that these are only cases with reported information on race and ethnicity. And as of today, about 27%, so nearly a third of case reports in Georgia were missing information on both race and ethnicity. So this is a problem. So the first thing I think about when I see numbers like that, right, is what do these numbers not tell us? So what can we not glean from looking at the numbers from the testing data, and how do we dig for those answers, right? And so many of you who are trained in public health are familiar with the burden of disease pyramid, which really just illustrates how all of the people who are infected with a condition, only a fraction of them become reported cases because, you know, in the case of COVID-19 especially, some are not symptomatic, some don't seek care, Some seek care but aren't able to get a test for whatever reason. And so what we're really seeing with the case data, which is what we were just looking at, is the tip of the iceberg. And this becomes incredibly important when you are comparing two groups, right, for whom the iceberg may be representing a different proportion of the overall disease. And so let's say we were reporting cases in one racial or ethnic group to another. We might, and remember, we're just looking at the tip of the iceberg here, so the top triangle, cases that are reported. So we might see just a slightly larger triangle or a slightly larger number of cases reported in one group versus another. But what we don't know is what's under that top triangle, right? And so if one group were more likely, to have symptoms but not seek care or to not be tested, the overall size of their burden of disease pyramid is going to be larger. But the problem is we can't see it because all we can see is the top of the pyramid. And this becomes very important with when we're looking at racial disparities, because we know that some racial and ethnic minority groups are less likely to be able to seek care and to be able to get a COVID-19 test. So it's a very important issue that we should be thinking about. So there are two main problems here with using testing data to measure racial disparities in COVID-19 infection. The first problem, which we just talked about, is that we only have information about people who test and are reported. And the percentage of infected people who are tested may differ by race, ethnicity, and it very likely does, right? So in epi terms, we call this selection bias. The second problem is that we are missing race ethnicity data for many reported cases, nearly a third in Georgia. And the percentage of cases that are missing data may also differ by race ethnicity. And so this is another source of sort of missing information. And in epi terms, we call this information bias. So I've been part of a team that's led out of Emory University to try to overcome these two challenges in measuring burden of COVID-19 disease. And we have launched an NIH-funded national serosurvey to measure burden of disease. And you can see a screenshot from our website here. The study is called COVID-View. And so what we're doing is we're using complex sampling methods to randomly select US addresses all over the country to receive at-home sort of do-it-yourself kits for COVID-19 disease and antibody testing. And alongside the testing, you also receive a link to a web-based survey where you can report information about your demographic characteristics and behavioral risk factors for COVID-19, so that we're really able to look at results alongside people's socio-demographic and behavioral characteristics, which allows us to begin to understand better how this disease is distributed across different kinds of populations, and to understand how these risk factors may be differential across populations. We're aiming for about 8,000 responses across the United States, so this is a huge undertaking. And the point here really is these data will allow us to really get under the hood of that population pyramid. So to look at what's going on under the tip of the iceberg and to better estimate population level burden of disease.
That's really fascinating. Can you give a little bit more details into what actually comes in the kits?
Sure, absolutely. So, so we have these really well-designed kits, and in my opinion, they look like they're being mailed out of Apple, really. But we have this little test kit here with our logo on it, and it has a number of things inside. So it has a nasal swab for testing for active infection. And this is just one of the short swabs that goes just right inside your nasal cavity. So it's not one of those sort of scary, painful ones that you have to push all the way back. It also comes with a single-use lancet, which you can see on the right here, and a dried blood spot card that allows you to just drop a couple of drops of your blood onto the card, and that's used for antibody testing. The box also includes some really nice illustration-based instructions and a link to our study website, which actually has some videos that show you in even more detail, how to collect the specimens. And it also contains a postage paid envelope so that you can easily just, collect your specimens, put it in the envelope, drop it in your box. It gets sent off to lab, and of course the study receives your results, but you also receive your results within about a week. So a pretty easy way to get tested for COVID-19 without leaving your house. Now, unfortunately, the study is not a magic bullet, right? There very rarely is one. We are getting a lot of great information, but we have been seeing lower response rates to the survey among African Americans and Hispanic Latinx populations compared to non-Hispanic white populations. And this is consistent with every other smaller serosurvey that's been conducted in the US at this point. We have about actually five now published studies that have been conducted in smaller settings, and we see the same problem across all of them. And so obviously this is really problematic because these are the populations that we're seeing high burden of disease in, and that we know the least about because they're probably underrepresented in the testing data compared to other people. And so there's a bunch of reasons that this may be happening, this lower response, very good reasons actually, maybe due to, distrust in medical research, concerns about sharing biospecimens, the current sort of racially charged US political climate, even operational reasons like limited time for completing a survey because, some, populations may be more heavily represented in, among essential workers. And so, these are just a few. There are likely many other reasons. So COVIDView, our survey is addressing this lower response using a multi-pronged approach. But one of the approaches that I'm most excited about is some qualitative research that we just launched. We're visiting households in the Atlanta metro area who received these kits but didn't respond. And these are households in census tracts that are highly represented by African American and Hispanic Latinx populations. And so we're really going door to door and requesting short conversations, including an incentive, of course, with folks just to talk about their decision not to participate. So I've shown you, a couple of the questions that we're asking in in-depth interviews here, general things like, what can you tell me about, what you thought when you received the materials? And one of the most exciting parts about this research is that we have our very own GSU MPH students leading the data collection. So they've been able to get trained in qualitative methods and are getting some great experience in collecting primary data. So we hope to use this information to really improve the inclusiveness of serostudies like COVIDView and help to ensure better representation, not just in our study, but in future studies monitoring the pandemic among racial and ethnic minority populations. So I'll wrap up my brief presentation there, and I'm happy to answer any questions, Brian.
Yeah, thank you so much. That was extremely informative about the research that you're doing. So following up with our next question, so can you go a little bit more in depth of why you think this research is so important?
Sure. So I think, it all goes back to thinking about, the population pyramid and what we're missing with the testing data, right? And because we think we're very likely missing more cases among racial and ethnic minorities, but we don't know how many more, it makes it difficult to, to appropriately prioritize prevention activities and to allocate resources where they're needed most. So if you think about, even future interventions like a vaccine that will hopefully be available in the coming months, what the surveillance data tell us is, what populations are most in need of that vaccine and where should we be prioritizing our efforts for vaccine distribution. And so if we're relying on the testing data alone to tell us that, we may not see the racial disparities that are sort of, exist under the tip of the iceberg. And so I like to talk about our, participating in our study, like, being counted by the census. We've been in census times recently. And so everybody's familiar with the messaging, if you don't participate, you don't get counted and you won't be represented in decisions that are made about resource allocation. And that the exact same thing applies here, right? So we need to have estimates that are really representative of the way this infection is distributed in our population and across racial and ethnic groups to make sure that we're prioritizing resources in the right way.
So that kind of leads me to the thought that you've heard a lot of question about the need for more testing. Why more testing is a good thing?
Why more testing is a good thing, or is we've been hearing both arguments, right?
Yeah.
why testing may be a good thing or not such a good thing. Well, yeah. So I think, again, drawing to the pyramid illustration, the number of people tested don't change the size of the pyramid, right? The number of infections the number sort of is what it is, right? And with less testing, we're just detecting less of the pyramid or less of the overall burden of disease. And so it gives us less information to act on. The more we test, the more of the pyramid we're capturing. And so the more accurate information we have available to us as public health professionals and policymakers to make, decisions about how to allocate resources and how to curb the spread of infection. More information is always better.
So I always like to ask the question of, as a community of concerned folks and can you tell us how we can become more involved with your research?
Sure. So I would say one thing, that we can do as a Georgia State public health community is to be, good, reliable sources of COVID public health information for our communities. I think, a lot of people don't know where to turn for reliable information these days. And so I'm guessing that a lot of folks in our public health school and alumni of our public health school are being asked questions, by their community members about, who to believe and where the best information comes from, right? And that may include some questions about participating in serosurveys, like the one that I've just described. And I think, one important thing that you can do is to really explain that assuming the serosurvey is being conducted by a reputable group with reputable funding, the purpose of the research is really to improve our understanding of burden of disease in communities, where people live. And so to just encourage people to let their voice, be heard, as it were, and to participate in research if they're called upon, to do so, because this is the only way that we sort of learn the truth about population level burden of disease and can act on it.
So on that note, if we know someone who's selected for this research or a similar study, do you have some tips or some steps that they can take to ensure that the test is legitimate?
I do. So the first thing that you would receive if you were selected for our survey is a letter in the mail, just introducing the survey and, and saying that in a few days you're going to get this test kit. But the letter in the mail has a link to our study website, and it also has a phone number that you can call 24 hours a day. This is being fielded by public health students at Emory. And so you could call that number, you could go to the website and, look at who's funding the study, read a little bit more about the study, call the number and ask questions. Any concerns that you might have about whether the study is legitimate, you should always feel free to take advantage of those information sources, and ask questions, right? And so I would highly encourage folks to do the research, before just sort of deciding that I didn't order this box and I don't know what this is, and so I'm gonna toss it.
I think you touched on this earlier, but I just wanted to follow up and see if you could provide a little bit more information. In regards to your research and impacting the community, how will it help us in getting out of the pandemic, and in what regards with vaccine research will it help in that process?
Sure. So I would say, any intervention that we implement to control this disease, including a rollout of vaccine, will depend on surveillance data, right? To help us understand, where the disproportionate burden of disease is, and who we should be prioritizing for interventions, right? And so anything that we roll out, the success of those interventions depends on having a clear picture of what the disease looks like in terms of its distribution in the population. This is sort of the core tenet of surveillance data, right, is that we use them to inform prevention and control interventions, and otherwise there's no need to collect the data at all. And so I think in terms of vaccine rollout, I would say two things, right? So one thing is that the survey data will tell us something about where we're seeing disproportionate burden of disease. I also think the qualitative data that we're collecting will be helpful in increasing our knowledge about why folks may not want to participate in COVID-19 research, and that may extend to not wanting to participate or to take a vaccine. And so I think by hearing people's concerns and trying to understand which of them are addressable and how we make both research and interventions more inclusive to racial and ethnic minority groups, we will be able to better reach people with interventions who really need them.
So I'm curious, what lessons have you learned from your work in HIV/AIDS research as it pertains to the current pandemic?
Sure. So that's an interesting question, because HIV is really the reason I got interested in racial disparities in health. We see massive racial disparities in HIV infection and outcomes of HIV, particularly among men who have sex with men in our country. So both African American and Black, as well as Hispanic, Latinx, MSM, have much higher HIV risk compared to white MSM. And, we were a little slow to pick up on this as a sort of public health field. And part of it has to do with, surveillance data, and part of it has to do with just, sort of not knowing what the right interventions were. And I think we're still working on knowing what the right interventions are, particularly to reach racial and ethnic minority groups. But what happens is that, as these disparities are not addressed, they become worse and worse. And so in the case of HIV, we now know that a lot of disparities in HIV, racial disparities, are attributable to the fact that with men who have sex with men, Black and Hispanic MSM have much higher HIV prevalence within their sexual networks, right? And so if even if these men had less sexual risk behavior than white men who have sex with men, the fact that they're more likely to encounter another man who has HIV, in a sexual encounter, they're so much more likely to encounter another man who has HIV versus a white man who has sex with men, that their risk for HIV goes up regardless of risk behavior. And so as HIV becomes more and more entrenched in those networks, the disparities become much harder to address. And I think we will see this with COVID as well. The longer we go without addressing disparities, the more entrenched COVID becomes in communities of color, and then it's really hard to dig yourself out of that.
Gotcha. Well, we have a couple questions that have come through from the attendees. The first, with regard to the door-to-door portion of the study here in Atlanta, what incentives are you offering to the participants?
So we're offering a $50 Amazon gift card for just about a 20-minute conversation. So that, to me, that seems like a pretty good trade. And plus, I think you get a few minutes to talk with some excellent GSU grad students about, about how how you think about decision making in these surveys, and even though that may not directly benefit you, sharing this information could be incredibly helpful, you know, to researchers who are planning these surveys and want to be, you know, reaching a broad range of populations.
And we have one more question from a current contact tracer for DPH. It says, when we do the interview with positive case or close contacts, many of them prefer not to answer their race or ethnicity. That's why we have a lot of missing data. When you do the study, how can we know it reflects the real population? I think people who participate in the study are more likely to provide their.
Yeah, that's a problem, right? I mean, that is essentially the crux of the selection bias problem, is that when when you talk to folks and you know, and they report their race, ethnicity, and you only report cases, or you can only report sort of racial disparities among cases where you know race, ethnicity, you're missing a huge piece of the puzzle there, right? And so we are getting much more complete data on race, ethnicity in our survey than we get in the case report data. And so I think the survey, you know, fills that need in a large way, in that folks who participate tend to be, you know, more likely to report race, ethnicity. Of course, the challenge is that we have to motivate people to participate in the first place.
So my final question, as an epidemiologist, what are some practical tips that you can offer as we continue to deal with the pandemic in our community?
Yeah, I mean, I would say be a good source of public health information for your community. Keep up with keep up with information that you trust, and be ready to answer questions that folks may ask you. Typically, you know, we do trust people in our social networks more than we trust, you know, the news. And so be a good source of public health information for folks that you talk to. The second thing I would say is, you know, we are all tired of staying home. I am still, you know, really quite quarantined at home. And I feel like, you know, a lot of weeks I don't spend a lot of time outside of my, my office and my desk chair. So I get that, you know, I get that sort of restless feeling, but I would say when you go out, please be a good public health example and wear a mask. If you've got a mask with a Georgia State logo on it, even better. You can rep the school while you wear your mask, but let people see you being a good public health citizen, and, you know, and protecting the health of people around you.
Great, thank you.
Thanks for having me. This was fun.
Yeah, thank you for sharing. That was very informative. I appreciate your time. I want to thank you all for attending the Currents of Public Health webinar today. And again, I want to thank Dr. Bradley for her informative presentation. Please save the date for our next webinar on October 29th at 12 p.m. featuring Dr. Amanda Gilmore, who will be discussing primary and secondary prevention of substance abuse and sexual assault. In closing, the School of Public Health at Georgia State is one of the most diverse schools of public health in the nation, offering a Bachelor of Science in Public Health, a graduate certificate, a Master's of Public Health degree and 5 concentrations, a PhD degree and 4 public health areas of knowledge, and a Doctor of Public Health degree. The faculty and students conduct cutting-edge research on the complex 21st century public health challenges facing cities across the globe. Our work is often carried out in partnership with communities, their residents, and community-based organizations committed to health equity. If you'd like more information about our programs and how to support the work of the school and our students, please visit publichealth.gsu.edu. Thank you for attending, and please join us for our next webinar.